Good evening, friends. So welcome to the Tuesday emergency and critical care updates and case presentations. We bring some different multi-speciality groups together to bring some interactive discussions. So today we have an interesting topic which we have been dealing in intensive care unit for the last couple of years or so in a good number. So we thought to bring these discussions to all of you. To bring a case scenario, Dr. Monica, our senior consultant in intensive care unit, will present a case, followed by our consultant rheumatologist, Dr. Keerthi Talari, will be talking or interacting with us as a part of the expert panelist. Welcome you, Dr. Keerthi and Dr. Monica, on the board.
Thank you, sir.
Yeah, so to start the discussion, I will invite Dr. Monica Soni to start the presentation of the case so that we can initiate the interaction. Over to you, Dr. Monica. Unmute yourself, Dr. Monica. Unmute yourself, Dr. Monica. Yes.
Hello, sir. Good evening, sir.
Yeah, good evening.
A very good evening to all the listeners out there. I'm privileged to present before you an interesting case concerning rheumatological emergencies in the ICU. So we have this patient, 29-year-old female, a police constable. She presented to us on 16th February this year to emergency room with chief complaints of bilateral lower limbs weakness for 15 days with difficulty in walking and standing up since 5 days. Weakness was progressively increasing and was associated with joint pains of the wrist. She also had complaints of shortness of breath of NIOH grade 2 for 3 days, and she was complaining of epigastric pain for the past 3 days. Regarding her past and personal history, she had a history of COVID-19 vaccination with Covaxin a month ago, and she is a known case of PCOD on treatment. And actually, the history of joint pain predated before the COVID vaccination, along with the fever 15 days ago. And there has been a history of hair loss, weight loss, and dry mouth for 1 month, along with a significant history of abortion in 2021. So once she came to us, we had this certain differential diagnosis with us. So commonly seen post-vaccination Guillain-Barré syndrome, oblique transverse myelitis, or myositis, given a history of fever with joint pain, tropical fever, and of course, autoimmune diseases. So when we had this Apache score 4 calculated, it was 50/226 with expected mortality rate of 5.9%. So on examination, I found her to be conscious, oriented, and afebrile. There was facial puffiness of 3+. And on palpation, the tenderness of both calves was present. And she had bilateral calves ecchymosis, which is visible on the picture next to you. And abdominal tenderness, bowel sounds were present, and there was abdominal guarding also. And auscultation of chest, she had fine cramps. So following her further examination, she had a sinus tachycardia at 140 per minute. And when she came from the ER to the ICU, she had a BP of 110/60 on infusion of noradrenaline at 12 ml per hour, which approximately comes out to 0.1 mics per kg per minute, with a breathing rate of 22 per minute. On examination of deep brain reflexes, they were depressed to areflexia, and bilateral upper limbs minimal grip with weakness was present. There were no sensory deficits, and bilateral lower limbs had a power of 1/5, and her adequate output was adequate. So these are the certain radiological findings which we did on day 1. Her 2D echo showed a mild LV dysfunction of 55% ejection fraction with mild pericardial effusion, concentric LVH, and IVC was collapsing. Her USG abdomen showed mildly gallbladder kidneys with perinephric fat stranding, bulky pancreas, mild hepatomegaly, bilateral simple ovarian cysts, and there was mild free fluid in the pelvis. CT chest also was done along with CTPA, which was negative for PE, pulmonary embolism, and it showed mild bilateral pleural effusion, subtle GGOs, and with atelectasis. So provisionally diagnosis, we came out to be autoimmune disease with septic shock or with myositis, with DVT, was a GB syndrome, post-vaccination status, with multi-organ dysfunction showing polycirrhosis, stress cardiomyopathy, mild acute pancreatitis, and transaminitis. So in the ICU, we had her flu resuscitated, guided by IVC assessment and clinical parameters, started on injection piperacillin tazobactam 4.5 gram IV TID, along with injection doxycycline 100 mg IV PD, along with other supportive treatment. Further investigations were ordered as per neurological team, MRI brain with LS spine, nerve connection study of bilateral lower limbs, and ANA profile. So from day 2 to day 3, her vitals continued to be stable. Infusion NORAD tapered to 2 ml per hour, maintaining adequate urine output. Facial puffiness came down to 1+. Still, calf tenderness was persistent. Abdominal pain subsided. There was increasing TLC, persistent hyponatremia. Tachycardia was persistent, along with always afebrile. So further investigations were ordered. ANA by immunofluorescence, anti-cardiolipin antibodies, IgM, IgG, angiotensin converting enzyme antibodies, CSF analysis for cell count, proteins, and sugars, anti-cyclic strolinated peptide anti-CCP antibodies, and RA factor. So these are the investigations which we had ordered, and out of which cardiolipin IgM antibody was strongly positive, 62.8. And in the myositis profile was negative, and ACP also was negative. And we had done her Cianca and Pianca, which is anti-neutrophil cytopenic antibodies, which are negative. And in the profile of ANA, we had RMP strongly positive, SM borderline, and SS doubled plus positive, along with PCNA positive, which indicated towards MCTD in case of RNP antigen, SM for SLE, double SAS, SLE with neonatal lupus, and PCNA for SLE. Her creatine kinase values also was high, 2,661. Complement levels were sent, of which C3 showed depressed component C3 level activity. And ANA, as we showed, it was IF was positive, strongly positive. Okay. So further elaborating on the investigations, the MRI brain showed no significant abnormality. The venous Doppler, bilateral venous Doppler for lower limbs was negative for DVT. ANA profile, as shown before, RNP SM3+, SS2+, PCNA 1+. And so on day 3, rheumatologist's opinion was sought. And so the diagnosis narrowed down to connective tissue disorder with SLE with inflammatory myositis. So on day 3, the treatment plan was to start hydrocort, 100 mg IV after primary and critical care team discussion. But after rheumatologist discussion, it was switched over to injection solumedrol, 1 gram IV OD for 3 days in a pulsing manner. Clinically, patient was stable. By day 3, the noradrenaline was straight weaned off, and her lower limb power improved to 3/5. There was improvement in lactates and ABGs as well. On day 5, further we sent, as we have sent, you have seen the levels, complement levels 3, 3, and C4 were sent, along with anti-beta-2 glycoprotein, IgA and IgM, and myositis profile. This was the day 2 of pulse steroid. The facial edema subsided. The power improved of the hip flexors between 2/5 to 3/5. Shoulder abductors were 3/5. And so a strong suspicion of SLE was suggested as by arthritis, myositis, polycirrhosis, and acute pancreatitis. On day 5 and 6, she had mild hypoxia requiring oxygen supplementation. The saturation at 2 liters oxygen was 94%. Chest showed mild basal crepes, rising lactates, X-ray chest showing bilateral diffuse infiltrates, hyponatremia resolving. So in view of clinically findings of fluid overload, of tachypnea and SOB at rest, we started diuretics. And at the same time, she was having rising TLC, but with no fever. So probably it was because steroid induced. And of course, her peripheral smear was showing just simple shift to left. And by this time, we had cultures of urine and blood cultures, which are reported to be negative. So on day 6, she had a dose of pulse steroid completed, and therefore it was changed to oral steroids, 1 mg per kg of omnocortal. On room air, she was maintaining good saturations. tachycardia and tachypnea present, but they were improved and started on tablet hydroxychloroquine 200 mg OD along with mycophenolate 500 mg OD added. By now, myositis profile also came, which was turned to be negative. As we have all seen, the complement levels also came, which was showing sharp decrease in the C3 levels. C4 were okay. And anticardiolipin levels also came, which was positive. So on day 7, patient was mobilized out of bed. She was ambulated. Central line and Foley's catheter was removed. Ultrasound again was repeated to show it was having normal pancreas. And the repeat OD echo showed normal elevated function with 65 ejection fraction. And so she was shifted to general ward. So this is the trend I would like to share with you all. The trend right from 16th of the day of admission, where she had raised lactates 3.49. The trend decreased on 17th, 18th, 19th, and on 20th, 21st, there was again rising because of the cardiomyopathy and because of the baby fluid overload. And on 23rd, again, it became 2.49, but otherwise she was clinically stable. Her TNC, she came to 16,460, and the maximum was reached on day 5, which was 24,960. And again, they came down to 16,000, and the last year, 10,000. HP was never a problem. Creatinine was never a problem. Creatinine was always maintained 0.5. D-dimers, of course, it was high. That's why we did CTPA. It was showing 2,331, and it came down to 1,849 on 22nd, which was day 6 of admission. PCT was always negative, 0.16. CPK on day 2 was 2,661. Amylase and lipase levels were normal, which on day 6, they increased to 115, and lipase 704. CRP on day 1 was 2.8. Transaminitis, mild. NT-proBNP was 26,000, and triglycerides was 450. So finally, we had a diagnosis in direction of SLE with associated myositis. So finally, when we are discussing this, I would like to suggest, I would like to say that the SLE diagnosis supported by the immunological findings of SM, SS, PCNA levels, and low C3 levels, because along with these findings, there were clinical features of myositis, arthritis, history of abortion, hair loss, weight loss, fever, rashes, and clinical features of pancreatitis and transaminitis. She was discharged with advice of statins like atorva, fenofibrate, hydroxychloroquine, anticoagulant like Eliquis, epiaxiban, bisoprolol for her heart failure, Evabrad for heart rate, Diator, omnacortal, and mycophenolate. And she was asked to review it after 1 week. So that was the presentation.
Yeah.
I hope.
Thank you, Dr. Monica, for that quick, brief summarization of this case. This has been a routine case for any rheumatologist or Dr. Keerthi to be a pattern which we see commonly across in any of our ICUs. So we just brought this case to initiate a discussion. So just to actually go back to this case, ma'am, what is your initial, what is your actually take from this case? We commonly see many of these, your ANA profile coming positive. Initially, I still remember when this case was presented to us after a vaccination, most of us still carried with the post-COVID Covaxin or Covishield related Guillain-Barré syndrome or AIDPs or some transverse myelitis or some kind of myositis and all that. And typically this lady initially from her complaints were weakness and her complaints were unable to walk. So that also actually diverted many of clinicians' mind from there. So these may not be very unusual as a part of the rheumatology OPD or a rheumatology complaints. What is your take when such case comes to a general clinicians or a intensive care setup complaining of a breathlessness, polyserositis? What is your take from this case, ma'am? Dr. Keerthi.
Yeah. Okay. Good evening, everyone. So, sir, first, the very first thing is like if any young lady comes with multi-organ involvement, you always need to suspect an autoimmune disease. And in this particular case, I think history clinches most of the times in rheumatic diseases, history clinches the diagnosis. So in this particular case also, if we actually probe into the history, she had a 2-month history of feeling unwell, like predominantly constitutional features, low grade fever on and off, weight loss, or decreased appetite. The presentation was acute with significant weakness. That is what she had actually come with. And when I had seen her in the ICU, she also had severe edema, like she had a lot of edema in the legs, in the hands, and in the upper limbs and lower limbs, which was suggestive of an inflammatory edema. And she definitely had a lot of proximal as well as distal muscle weakness. Her hand grip was decreased as well as her shoulder abductors were completely weak. She had a lot of neck flexor weakness. So both proximal and distal muscles were equally involved. So she basically had a combination of myositis plus neuropathy. That is when I had asked for a CPK total. And so basic point is suspecting a rheumatologic diagnosis in an ICU setup would be there, especially when you are having patients who have multi-organ dysfunction in younger people, where you do not find any other risk factors. And they also give you a prolonged history of feeling unwell. So there'll be certain subtle signs which we need to pick up. For example, if a lupus patient comes to us for the first time in an acute presentation, a clinical examination sometimes might just reveal a discoid rash in the ears and or a palatal ulcer which was missed, or a vasculitic rash in the lower limb. If you would actually look at her lower limb, she had these ecchymotic kind of lesions which were more like vasculitic lesions in the calf region. So those subtle signs have to be picked up to suspect an autoimmune disease.
Okay. If Dr. Monica, can we go back to that ANA profile? So we tend to see many of the reports being many antibodies being positive, and we do understand in the lupus itself you can have a multiple antibodies coming positive. So in this patient, the clinical presentation had a lot of suggestions, like this patient had a muscle involvement, severe pain, and also weakness and all. But other way, this kind of when we get a report, how do we interpret from a rheumatological point of view in an intensive care unit? We sometimes see a cross reactivity, sometimes see a false positivity, sometimes also we see a cross reactivity. So what is your take when should we actually order this ANA by IF? And sometimes we see people directly ordering ANA profile before ANA. So, and there are different methods which ANA been done, like we do it by ELISA, we do it by immunofluorescence. So what are those takes, ma'am?
Yeah. So we order ANA when we are suspecting an autoimmune disease. So that is the first thing. And when do we suspect an autoimmune disease? As I have already told, young people presenting with multi-organ, I'm talking in terms of an emergency setup, because on the OPD basis, if a young female comes with arthritis also, then also we will evaluate we will do an ANA in that person. But in an ICU setup, if you're getting a young person with multi-organ dysfunction with no obvious evidence of infection, and if there are subtle signs of an autoimmune disease, that's when we order for an ANA testing. Now, ANA is usually tested by 3 methods. One is the ELISA, the second one is immunofluorescence, and the third one is immunoblot, which we commonly call as the ANA profile. ANA ELISA is neither very sensitive nor very specific for diagnosing. You can just tell an ANA is positive. It can very well miss an ANA positivity, because in ANA ELISA, what is actually done is the nuclear antigens are coated on the ELISA wells, and the patient's serum is added to detect if there are antibodies. So not all nuclear antigens can actually be coated on an ELISA well, but it's a cheaper test compared to immunofluorescence or profile. So the role of ANA ELISA is only when you want to screen a larger sample of people, or in primary care setups where doing an immunofluorescence or an immunoblot would be more tedious. Immunofluorescence is the best way to screen for anti-nuclear antibodies, because in immunofluorescence, what we actually do is we use cell lines. So all the nuclear antigens are there on the cell lines, and then add the patient's serum and then look for the anti-nuclear antibody. So obviously, you're looking at antibodies against all the nuclear antigens. So that is the best screening method for anti-nuclear antibody. And the advantage of ANA by immunofluorescence is you get patterns. So we get homogeneous pattern, post-speckle pattern, fine speckle pattern, cytoplasmic pattern. So depending on the pattern, we can actually tell which antigens is this ANA against, and accordingly we can make a diagnosis. So for example, if we get a homogeneous pattern, it is usually against double-stranded DNA, single-stranded DNA, histones, or nucleosomes. So one of these antigens. And that would definitely mean that this person probably has lupus, because homogeneous is something that's very characteristic of lupus. On the other hand, when we get a speckle pattern, now the speckle pattern can be because of a lot of nuclear antigens. So if we want to pinpoint which particular nuclear antigen this is against, that is when we order an ANA immunoblot. ANA immunoblot is definitely not the first test that needs to be done when an autoimmune disease is suspected. ANA immunofluorescence is the first test that needs to be done.
Yeah, so the other part of the question is, ma'am, many of the times we do understand the common population also can have ANA positivity, and there will be numerical cutoff values. If you see the titers, which we mean to say, when you take 100, when you take 40, you have a different sensitivity and specificity, as you rightly pointed out. So what are the chances of, and see, if you send this vaguely without an indication, what can be the implication of this interpretation?
Yeah. So the first thing is we should never order an ANA just like that. So if the suspicion of an autoimmune disease is there, that is when an ANA should be ordered, because ANA in itself can be positive in low titers in the normal population. And as a person ages, the chances that they would have an anti-nuclear antibody is much higher. So if you actually take somebody who is above 60 years, an ANA can be positive at the range of 20% at a titer of 1 in 100, which is the usual titer which we check for. So that is the first implication. So basically ANA titers, like we basically look at this baseline. There is something called baseline titer that they mention when they give an ANA immunofluorescence report. The titer has to be 1 in 100 and above. Anything lower than that could just be a false positive ANA also. The endpoint titer shows how strongly positive the ANA is. Suppose we have a 1 in 360 or 1 in say 640 titer, then definitely the ANA is very strongly positive. That is one thing. Giving importance to the ANA also depends on the titers, then depends on the positivity. Like somebody was asking, right, whether should you give importance to a weak positive ANA? Now, a weak positive ANA in a titer of 1 in 360 or 1 in 320 would definitely be significant, as against a weak positive titer at 1 in 40 dilutions. So basically the dilution matters, the positivity matters, and more important than that, it is the clinical scenario. Suppose the clinical scenario is in no way tallying with the ANA positivity that we get, and the ANA is weakly positive, we should really not give importance to it, because it could just be a rider in that particular case, where it would actually misguide you to treat a patient who probably has an infection with steroids.
Yeah, so ma'am, we just wanted to know, in the context of intensive care unit, as you said, we are talking about autoimmune diseases now, and today's topic is rheumatological emergencies. So we term rheumatology and emergencies related to the rheumatology. And we also now having a new term coined like autoimmune inflammatory or autoinflammatory diseases. And now we are also talking about all these categorized as a connective tissue disorder rather than rheumatological disorders. And then we are talking about very many overlaps. And lastly, the vasculitis, when we speak about more of a small vessel vasculitis in the form of pulmonary nulls and all. So can you just clarify those terms and how we actually use these terms? Because many of us, when we use autoimmune, what are the cover, rheumatology, what are the cover, and all that?
Yeah. So basically, when we say rheumatologic conditions, any condition that affects the musculoskeletal system or the connective tissue disease comes under a rheumatologic condition. When we say connective tissue disease, it could basically mean involvement. Connective tissue disease means the connective tissue is involved here. So the connective tissue could be anything in the body. It could be the vessels, it could be the muscle, it could be the bones, it could be the joint. So all these are like just vaguely grouped under conditions called connective tissue diseases. Now, connective tissue diseases can either be inherited or could be autoimmune in origin. So the inherited connective tissue diseases will include all those Marfan syndrome, Ehlers-Danlos, and all that group of disorders.
Yes.
While when we talk about a CTD, it primarily means the immune-mediated connective tissue diseases. So among the immune-mediated connective tissue diseases, now we have terms like autoimmune and autoinflammatory. The difference is we have two types of immune system. One is our innate immunity and the other one is adaptive immunity. So diseases which are mediated by the adaptive immune system, that is the T cells and B cells, those type of diseases are called autoimmune diseases. So lupus, Sjogren's, scleroderma, inflammatory myositis, all these come under the autoimmune group of diseases. While those diseases, rheumatoid arthritis also is an autoimmune disease. While those diseases which are predominantly mediated by the innate immune system, that is macrophages, NK cells, neutrophils, come under the autoinflammatory group of diseases. And here we have familial autoinflammatory syndromes, and among those which occur in the adults, spondyloarthritis, adult onset Still's disease, these all come under the autoinflammatory syndromes. The basic difference between the two is you'll usually have autoantibody positivity in autoimmune diseases, while in autoinflammatory syndromes, it will be markers of the innate immune system which would be positive.
These kind of things do get overlap, ma'am. We see overlap of these disorders.
Yeah, so overlap syndromes are basically when we have two diseases being together. Usually, we do not expect an autoinflammatory syndrome and an autoimmune disease to be together in a particular person. So autoimmune diseases can overlap. Like rheumatoid can overlap with myositis. SLE can overlap with systemic sclerosis. Systemic sclerosis can overlap with the Sjogren's, which is rheumatoid with Sjogren's is the most common overlap that we see. So overlaps can happen between two autoimmune diseases. It's highly unlikely that an autoinflammatory disease can overlap with an autoimmune disease. And then coming to vasculitis, because you had asked about that also. So vasculitis is basically inflammation of the blood vessels. There is inflammation in the blood vessel wall. There is infiltration by neutrophils or immune cells, which is causing destruction of the media of the vessels, resulting either in rupture of the vessel wall or resulting in aneurysm formation in the vessels. So vasculitis again can be primary when only the blood vessels are involved, or it could be secondary when it is a part of an autoimmune process or an autoinflammatory process that's affecting multiple organs in the body.
Okay. Now, ma'am, again, confining to the intensive care unit and a sicker group of patients, we do understand all the spectrum of diseases can have a OPD-based presentations or a milder symptomatic presentations, as you said, constitutional presentations, musculoskeletal presentations. But if we focus today more on the sicker group of patients in these all categories, which the spectrum which we are discussing about. So what are the common sick or a critically sicker group of these autoimmune patients who commonly present to the intensive care unit? And can you enlist them, and then we will go further into the discussion?
Yeah. So when we talk about rheumatologic emergencies, here I would not like to talk about emergencies because of the medications that we use in rheumatology. Neither would I be talking about emergencies that can overlap with rheumatologic conditions. So specifically for rheumatologic diseases, the most common emergencies that we encounter are usually seen in patients with lupus and vasculitis. These are the two most important things. So among patients with SLE, the most common emergencies that we encounter are one, a rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, a CNS vasculitis, a severe myositis, as we've seen in this case, resulting in pharyngeal and respiratory muscle weakness in certain people, macrophage activation syndrome when the lupus is extremely active. So these are myocarditis resulting in an acute heart failure are the rheumatologic emergencies that we see in lupus. When it comes to vasculitis, small vessel vasculitis especially, again here the most common rheumatologic emergency that we see is diffuse alveolar hemorrhage with a rapidly progressive glomerulonephritis. In lupus, in patients of lupus who also have antiphospholipid antibodies, catastrophic APS is a rheumatologic emergency that can happen, but it's a very, very rare condition that usually happens because APS in itself is a rare disease. CAPS is a much, much more rarer entity. And in scleroderma renal crisis, but we hardly see it these days. So scleroderma renal crisis is another rheumatologic emergency that we can experience. So, and obviously patients who, sorry sir.
Yeah. Ma'am, as you said, lupus antibodies can be a phenomenon in antiphospholipid antibody syndrome. There can be other than lupus also, we can also get antiphospholipid antibody syndromes where you can also have this catastrophic.
So
what will be the presentation? Because you have explained lupus related things. Other than lupus, what can be the other presentations of this antiphospholipid antibody syndromes?
Yeah, so antiphospholipid antibody syndrome can either be primary when it exists solely without any other autoantibodies or without another autoimmune disease, versus it could be secondary where it is seen in the presence of another autoimmune disease, most commonly lupus. So the primary antiphospholipid antibody syndrome is associated with two main complications. One is thrombotic manifestations and the other one is obstetric manifestations. And most of us know that if somebody is having recurrent first trimester miscarriages, that's more than 3 miscarriages, or somebody is having second or third trimester IUDs which are unexplained or which are associated with hypertension or decreased placental flow or an IUGR, that's when we should suspect antiphospholipid antibody syndrome. And thrombotic manifestations could be in the form of microvascular or macrovascular thrombosis. And these are usually associated with the autoantibodies against antiphospholipid and against phospholipids, which are measured in the laboratory by 3 main criteria antibodies, which are antiphospholipid antibodies, IgG, IgM, sorry, anticardiolipin antibodies, IgG, IgM, anti-beta-2 glycoprotein 1 antibodies, IgG, IgM, and lupus anticoagulant. Now, another rare manifestation of APS is when they have catastrophic APS. So here what happens is they have a thrombotic acute thrombosis, predominantly microvascular thrombosis, involving multiple organs in a time span of over a week. So they could be, so the presentation would also be like that. They would have multi-organ dysfunction. There would be evidence of demonstration of thrombosis. For example, if it's a CNS, we could notice a lot of lacunar infarcts. If it's the spleen, you could actually notice splenic infarcts. So ischemia would be manifest, like there could be digital ischemia, and organ dysfunction sets in very, very fast. And all this happens over a period of 1 week. And typically there could be microangiopathy noted on the peripheral blood smear. Now, this is a very difficult condition to diagnose because very similar features are seen in other microangiopathic hemolytic anemias like TTP, HUS, DIC, HELP syndrome. So that distinguishing part becomes very, very difficult. And basically, it is ultimately the antiphospholipid antibodies which will give us a key to diagnose this particular disease.
Yeah, ma'am, that is the one of the biggest challenge which we face day in and out in intensive care unit, ma'am. See, most of these cases, when you said multi-organ failure, we do see them in hypertension. We do see them having a systemic inflammatory response. The inflammation will be on. So as I understand, most of these patients received from the emergency room, considering as a sepsis as a provisional diagnosis with multi-organ failure. And most of the times these patients will be on broad spectrum antimicrobials, cultures will be awaiting. And we see them, there is a florid rapid deterioration over day in within a few hours to a day. So it is almost a difficult task at the initial presentation if a young girl presents to us in this situation. So what is your take in this situation? I do understand empirical antimicrobial cultures will be done, but in situations, in these situations, what should be as an intensivist keep his other differential lateral thinking on in this context of a multi-organ failure patients coming to you. Already pointed out few hints that it's young, no comorbidities, unexpected, unexplained sepsis, but any other clinching points differentiating from a sepsis organ failures?
So at times it becomes very difficult to distinguish the two. But as I said, clinical examination is one thing. Like if you really note rashes that are very typical of lupus, rashes that are very typical of suppose a dermatomyositis, or skin manifestation that's very typical of say systemic sclerosis, then they could all hint towards an autoimmune disease. When it comes to our investigations, we don't so quite often see leukopenias in sepsis. Of course, severe sepsis can also have leukopenia as one of its manifestations, but usually you expect a higher TLC in sepsis. So except in inflammatory conditions like myositis, most of the times patients who have lupus present with leukopenia rather than presenting with leukocytosis. That's one thing that you can look at. They'll have
that may also be a little tricky in situations with viral syndromes, like when we come across a dengue hemorrhagic shock syndrome, you do see leukopenia and you do see a multi-system involvement, you do see polyserositis, sometimes you do see the rash. So it will be a close mimic to your many of your, and most of our sicker group are young patients.
Yeah, so so the rashes of dengue are quite different from the rashes of a lupus or a vasculitis patient, sir. That's one thing. And yeah, definitely you may always get confused between dengue and a connective tissue disease. But the certain times, as I said, the history is the clinching part. Dengue is of a very short duration.
Very short duration.
While a patient who has an autoimmune disease would usually have a longer course. Having said that, there could always be acute presentations of autoimmune diseases, and that thinking should go on parallelly, and we have to evaluate on those lines. And since we have, luckily in our hospital at least, we have a turnover time of 24 hours for anti-nuclear antibodies. So these would help us in getting to the diagnosis earlier.
Okay. Suppose I have a patient where the two diagnoses, as you said, it is clinically sometimes not, it is next to impossible to actually differentiate between them with a definite way. So you keep both the diagnoses on a differentials and evaluate the patient. In those situations, we do cover them with empirical antimicrobial after appropriate cultures. So in those contexts, what will be the add-on therapies in waiting for a report in whatever you said, it may take 24 hours of time. So for example, we do use steroids in them in a stress dose when they are hemodynamically unstable. But those steroid doses are around 200 to 300 milligrams of hydrocortisone over 24 hours in an infusion if my patient's hemodynamics are unstable on a vasopressors. So, but in the situations where you feel a young patient, not very sure whether it is a septic, whether it is a autoimmune, initial 24 hours, what will be our take in those situations?
So I missed your last point. There was a
ma'am, if a patient who is presented to the intensive care unit where we have suspicion of both, and we are not definite of one over the other, and we are still evaluating and waiting for the investigational report to come back. Most of these patients do receive empiric antimicrobial with the cultures awaited. And some of these patients who are on vasopressors requiring, and still the MAP is staggering in and around a MAP of 70, we do supplement with some low dose steroids of 200 to 300 milligrams over the 24 hours. So do you suggest or recommend something else to be done in this situation where other alternatives are also on card?
So I'll definitely not suggest starting off high dose steroids or any other medications for these patients where the suspicion of an infection is also very strong unless and until we prove a diagnosis of an autoimmune disease. Certain times what happens is even in a patient who has an autoimmune disease, we know that the autoimmune disease is very active, say lupus is very active, and this patient also has an additional infection. even in those situations, we go wrong at times by giving them steroids or any other immunosuppression at that point of time, because they could be having an underlying infection which we wouldn't have recognized with the patient when the patient has an active disease. So when we know that there is an equal chance of it being sepsis versus an autoimmune disease, I would definitely not recommend that we treat the autoimmune disease till we prove that this patient has an autoimmune disease.
Okay. Now coming to the other area, ma'am, we do understand some of these patients who may directly present to us by some trigger, some initiating factor. And sometimes you do also accept that it can be an infectious agent, a dengue flaring an autoimmune disease, a infection flaring an autoimmune disease, some sickness, even COVID flaring an autoimmune disease being a phenomenon which we have seen. What is your take on those?
So if there is an underlying infection that is causing a flare of an autoimmune disease,
which was never diagnosed before. He's a known case, they are different.
So you're talking about a new patient who comes to us with an autoimmune disease, but also has an additional infection, an active infection at that point of time.
Yes, probably so infectious agents triggering an autoimmune disease.
So infectious agents can definitely trigger an autoimmune disease, sir. So as you said, a viral infection could be the starting point of lupus. COVID vaccine could be the starting point of an autoimmune disease, and we are seeing those kind of cases also. So COVID vaccination can also induce an autoimmune disease. COVID infection can also induce an autoimmune disease. So in such a situation, most of the times the infection would have subsided by then. And if the autoimmune disease is quite obvious, then obviously we'll be treating the autoimmune disease. The situation gets tricky when a patient has a severe autoimmune disease plus the patient has an active infection. So when we know that the patient also has an active infection, say a bacterial sepsis, and the patient also has an autoimmune disease that requires addressing, that is when agents which can be given during sepsis, I mean immunomodulating agents which can be given during sepsis would actually come into play. And here we have two main medications that we usually use, two lines of treatment. One is IVIG and the other is plasma exchange. The role of these two agents come in when there is a suspicion of sepsis. I mean, there is sepsis plus the patient is having an autoimmune disease flare. Because in this situation, we cannot give the patient steroids or we cannot give the patient immunosuppressants.
Okay. We have some audience questions, man, which we'll take. Often N profile is negative, even with 1:100 titer or more of ANA being positive in IF. So what is your take on that? ANA profile is negative with the ANA titer, which is 1:100 or more.
So, so even if the ANA IF is 1 in 100 or more, and the ANA profile is negative, it would only mean that either the ANA profile was falsely negative or the antibodies against which the ANA IF was detected. For example, suppose we say we have an ANA IF that is showing a speckle pattern on the IF, but the profile is negative. The antigen against which the antibodies were there on the IF are not checked on the ANA profile. Only a fixed set of antigens are checked on ANA profile. So if that antigen is not there in the immunoblot, obviously it would not be detected.
So what will we do in that situation? What will be the take of that ANA profile?
Again, the clinical scenario matters, sir. If the clinical scenario is very much suspicious of an autoimmune disease and you know of antigens against which antibodies could exist, which and we know of that particular condition where antibodies against a particular antigen which are not checked in the immunoblot can exist, then obviously we would consider that as positive.
Okay. There was another question related to a patient of 60 years with constitutional symptoms, but ANA profile was negative, but CPK remained more than 9,000, suggesting some form of myolysis going on. So what is the take on these cases?
So now we have a case of myositis, obviously not something that is happening congenitally, not an inherited condition, because the patient has a presentation only at 60 years of age. So automatically, this probably would be an inflammatory myositis. To confirm your diagnosis, we can actually do an MRI of the thighs to look for STIR or T2 hyperintensities in the muscle fibers. Or we could do a muscle biopsy to show an inflammatory myopathy. Now, inflammatory myopathy at this age may not always have an ANA positivity because inflammatory myopathies can have autoantibodies which are not detected on the ANA profile. An ANA immunofluorescence in these kind of patients can show a cytoplasmic pattern, but they could be autoantibodies which may be positive on the myositis profile. That's one thing. Another very common thing that we see in these people is an immune-mediated necrotizing myopathy, which can be seen after administration of statins, where anti-HMG-CoA reductase antibodies could also be positive in certain people, and anti-signal recognition peptide antibodies can be positive in other set of people. These are not usually detected on our ANA immunofluorescence also. So these differentials have to come into our mind when something like that happens.
So
and suppose we diagnose such a patient as an inflammatory myopathy, obviously the treatment would be like that of an inflammatory myositis.
Yes. So there were questions related to the complement levels. What is the context at which point you will send this complement level, and what are the implications when it is low or normal? How does it actually helps in your clinical management?
So to us, complements basically mean that when complements are low, there is a lot of consumption of complements that is happening in the body. And so all diseases where you have autoantibodies directed against antigens, the complements would be consumed to cause destruction in that particular organ. So a low C3, C4 for us would mean an active disease. Having said that, while conditions which are not complement mediated, like the ANCA-associated vasculitis, which is not a complement mediated disease, there you would not get a low complement level. That is one thing. Having said that, complements can also be low in sepsis itself. In severe sepsis, complement consumption can also happen. In the initial stages of sepsis, there'll actually be hypercomplementemia because there is inflammation inside the body, resulting in more complement production.
Yeah, ma'am, there was a point which you mentioned that macrophage activation syndrome can be a phenomenon which we see in some of these lupus patients, and I do see hematology gets overlapped with rheumatology also in all these contexts.
Yes.
So you mentioned adult stills being an autoinflammatory disease. You categorize that in autoinflammatory. I could see that. And now we are talking about macrophage activation syndrome, HLH, being another spectrum of category where you see cytopenia, where you see acute inflammation going on. So how you categorize it? Will become under autoimmune or autoinflammatory, HLH, macrophage activation syndrome?
So macrophage activation syndrome in itself is an autoinflammatory disease, sir. However, in autoimmune diseases, when there is there's excess activation of the immune system, the innate immune system can also get activated. So this concept of autoimmune, autoinflammatory is slowly fading and merging into each other. Because at one point of time, it was always believed that lupus is a B-cell mediated disease. Later, T-cells have come into play. And now we know that lupus can also be caused by neutrophil extracellular traps, and neutrophils play a very significant role in the pathogenesis of lupus. On similar lines, dendritic cells, especially plasmacytoid dendritic cells and interferons, have been implicated in lupus pathogenesis. So the latest drug that has been approved for lupus is also an anti-interferon alpha drug. So this division that only adaptive immune system is involved in this disease, only innate immune system is involved in this disease, is slowly merging. So obviously, even in patients who have a B-cell mediated disease, hyperinflammation can actually result in overactivation of the innate immune system. And macrophage activation syndrome can be seen as a complication of autoimmune diseases also.
So there were questions related to, we have already spoken about the triglycerides, sometimes ferritin, sometimes D-dimer in this case. See, this patient when presented with a calf tenderness, and this patient when D-dimer was elevated, and this patient had a limitation of the mobility, there was always a suspicion the hypoxia may be related to some form of a thrombus both in the lower limbs and maybe an embolic phenomenon. So these all are, we know, can be an acute phase reactants where these all can be elevated in inflammatory conditions. including during this COVID, we have seen many interleukins, C-reactive proteins, ferritins, LDH, and D-dimer all being a part of the evaluation of an inflammatory phenomenon. And in this HLH, which we know in triglycerides will be measured, some of the times we see the ferritins will be measured, and you see them finding to be high. So in clinical context, cytopenia with a clinical context with these inflammatory markers being high may give you a clue. How do you take that HLH diagnosis or HLH? Students or participants are asking, when do you suspect or kind of find a HLH being a component?
Yeah. So basically, HLH is basically primary or secondary. So primary HLH is something that usually is seen in the younger people, while secondary HLH can be macrophage activation syndrome, as we see with our autoimmune diseases. Now, I would say macrophage activation syndrome to us is a spectrum. There could be patients who have an incomplete macrophage activation syndrome to patients who have the florid macrophage activation syndrome, where our criteria are applied, like where people have high-grade acute onset, high-grade fever, high ferritin levels, high triglycerides, low fibrinogen, elevated transaminase levels. So the typical manifestations of macrophage activation syndrome, when they are there, the patient usually is very sick, has an acute presentation, has an underlying rheumatologic condition, and then they present with these kind of symptoms. But we could also have an incomplete macrophage activation syndrome, where a patient who suppose has lupus, has a flare, has some features of macrophage activation, like they have cytopenias, they could be having hemophagocytosis on the marrow, they could be having an elevated ferritin and nothing else. I mean, the other manifestations may not be there at all. But these patients could actually progress to a complete macrophage activation, a typical macrophage activation syndrome. So they should be treated as intensively as those who have a complete mass. Now, the difference between a primary HLH and this is that in conditions where we have macrophage activation syndrome secondary to an autoimmune disease, treating the underlying autoimmune disease appropriately itself would actually result in the macrophage activation syndrome subsiding. So we really do not go to drugs like etoposide or cyclosporin to control the macrophage activation syndrome in these patients. We treat the primary disease itself. On similar notes, even sepsis can cause a macrophage activation syndrome.
True. We have
so
seen
there,
that.
we actually treat the infection rather than treating the macrophage activation syndrome.
Yeah, that's a tricky situation. So etoposide, cyclosporin, even though there may be a treatment for primary, in a sepsis-induced secondary HLH, it will be a tricky situation for that. And when it comes to differentiating between adult stills and macrophage activation syndrome, both will have a higher inflammatory markers, but most of the times we see cytopenia in HLH and maybe leukocytosis.
Even adult, the most common cause for macrophage activation syndrome among autoinflammatory autoimmune diseases is Still's disease.
Okay, so it is again initially to start with adult stills and then unflurriedly attacking the system and then causing this kind of HLH. And there, I think rash and joint pains being a more predominant features in adult stills over HLH, or we can see both happening in adult stills will have more rash, joint pains compared to what we see in HLH.
You're talking about primary HLH, sir, or?
No, I'm talking about adult stills. The criteria.
Adult onset Still's disease usually has fever, inflammatory arthritis, and a migratory rash or an evanescent rash as its main manifestation. But when an adult onset Still's disease patient develops macrophage activation syndrome, they could be having these underlying symptoms or signs, plus they'll have all the features of macrophage activation syndrome.
Okay. So now we have understood the spectrum at least. So you spoke about lupus and you emphasized a lot on lupus related emergencies. You said all the lupus flare, spectrum of lupus flare from CNS vasculitis, seizures, altered sensorium, encephalopathy related to that. Then you spoke about renal lupus catastrophes, and then you spoke about the pulmonary manifestation or systemic manifestation related to the lupus. And then we went into catastrophic APLA, where it can be a part of lupus or other than lupus with catastrophic APLA. And then you spoke about diffuse alveolar hemorrhage, pulmorenal phenomenon with vasculitic phenomenon. And lastly, we also discussed about the macrophage activation syndrome. If we categorize all these 3 or 4, which are the most common rheumatological emergencies which we encounter in ICU. So if we suspect them, so in an intensive care unit, we investigate them. In this time, before we come to a conclusion, how do we approach? And once we actually get these reports on, how do we proceed in the management?
Yeah. So, so if a person has a pre-existing autoimmune disease and they come to the emergency with a complication, I mean, that complication could be anything. Suppose they come with breathlessness. So our differentials should include all the causes of lupus plus infections that can happen in a lupus patient because of immunosuppression. So if somebody comes with breathlessness, if a lupus patient comes with breathlessness, my differentials would be lupus pneumonitis, then diffuse alveolar hemorrhage, a myocarditis resulting in pulmonary edema, or a infection affecting the lungs. So, or an acute kidney injury secondary to a glomerulonephritis resulting in breathlessness secondary to
Fluid hold.
so these all would be in our differentials. It becomes a necessity for us to find out what exactly is the cause for that. On similar lines, if a patient of lupus comes with LV dysfunction, we also have to we have to evaluate whether it is secondary to sepsis or is it because of myocarditis secondary to lupus. As I said, certain times it becomes very difficult even despite complete workup to actually pinpoint and tell us whether this is an autoimmune disease flare or an infection which is causing it.
Okay, what is the role of procalcitonin you believe in these situations?
I only believe that procalcitonin is very much specific but not sensitive at all. So you could say that a negative procalcitonin, I mean, studies have
Negative
also
predictive
shown
value may have a help to say, and most of the times our role may be add on to our clinical context, but not relying it alone, because
a
many of the
positive
times,
procalcitonin does not mean anything to us.
yeah. So most of the times, I do see people relying a lot on procalcitonin. Based on the procalcitonin, they treat the patient feeling it is an infection, but many of the autoinflammatory conditions also we can see a rise in procalcitonin. Alone procalcitonin may not add value, but yes, in the clinical context, adding to our all clinical evidences, you may add to that. And negative procalcitonin may give you a negative predictive value, which may have a more reliability than a positive predictive value. We do use it for more of de-escalation, for antimicrobial de-escalation, discontinuation, rather than treating patients only on the reliability of a procalcitonin in that. So the next part of the question, ma'am, the management strategies. So when do you consider steroids in them, and when you consider the next layer of therapies like we say plasma exchange, then coming to the IVIG, then coming to the monoclonal antibodies, what will be the flow in most of these flare cases or catastrophic applications?
For catastrophic APS in specific, sir, or autoimmune disease?
Autoimmune in general, and then you can actually, all of them may have a varied in their
Exactly.
treatment.
So
So you can,
basically, the choice of immunosuppression depends on the primary diagnosis. So if we have a small vessel vasculitis presenting with diffuse alveolar hemorrhage and a rapidly progressive glomerulonephritis, steroids is the first choice of therapy. We give them pulse steroids. Our first choice of immunosuppression would either be cyclophosphamide or rituximab. When it comes to lupus, if it is lupus nephritis which is causing a problem, our first choice of therapy would again be steroids plus cyclophosphamide or mycophenolate mofetil if it's not too severe. But when there is a multi-organ involvement in lupus, it's always cyclophosphamide first, because that's the only proven therapy, though the evidence is not very strong in favor of cyclophosphamide also. Now, rituximab becomes a second-line agent in lupus. So when person is having active lupus and is not responding to steroids plus cyclophosphamide and is having an active lupus flare, that is when rituximab comes into play in refractory cases. IVIG, as I said, is again for refractory diseases or in patients who have an underlying infection. So IVIG plays a huge role when person has a concomitant infection because it does not immunosuppress the patient so much. Now, plasma exchange as such has role in certain situations only. For example, a good pasture syndrome is the perfect place where plasma exchange has to be used. An ANCA vasculitis with anti-GBM antibodies, when you have double positive antibodies, plasma exchange plays a major role. We do give plasma exchange in ANCA-associated vasculitis when there is RPGN plus diffuse alveolar hemorrhage. But the evidence for plasma exchange in ANCA-associated vasculitis is not so much. When it comes to catastrophic APS, the treatment of choice is anticoagulation because the primary problem there is thrombosis. Steroids have a role in steroids also have a role in catastrophic APS, but in a primary APS, when there is no catastrophic antiphospholipid syndrome happening, there is absolutely no role for steroids. There, in refractory cases, we can consider rituximab, we can consider plasma exchange, extrapolating the data from TTP, because that's also a microangiopathic process. And yeah, so that's the basic.
You mentioned about anticoagulating the catastrophic apply, which may be the primary therapy because clogging of the large and small vessel is the cause for this most of the organ failures. But many of the times we do see coagulopathy in them. So how do you take anticoagulation?
So basically, in such conditions, so coagulopathy in APS is not a very common thing. Once you have to start considering other possible diagnoses like DIC, or if it's in a postpartum state, help has to be considered, or a TTP has to be considered. But if we are actually seeing a coagulopathy, which can happen sometimes in APS, especially with an associated thrombocytopenia, steroids also play a major role in because there that steroids would be responsible for improvement of platelets, and then later on anticoagulation may have to be added. But in CAPS, anticoagulation is the treatment of choice.
Okay. Dr. Monica, what will be your take from intensive care perspective in these autoimmune diseases?
First of all, we have to have, as an intensivist, also a basic knowledge about how autoimmune diseases can present without knowing exactly that this patient coming with the autoimmune disorder. So as seen in my experience of a couple of years, I have seen SLE being the most common presentation after the investigations have been done when pointing towards the autoimmune diseases. And one or two patients have had who have come SLE with flare-up. So, and one or two patients have been diagnosed per se upon coming to the ICU. So as an intensivist, it's still, I'm going deeper and deeper into the nuances of the autoimmune diseases as to how to go about. So I would first stress around the proper history taking, which is very important, because a point which may appear insignificant to us, like the feeling of generally feeling unwell or feeling of malaise going on for 2 or 3 months, which may seem to be insignificant, but that could be an important clinical history in terms of diagnosing autoimmune disorders. Secondly, the differentials have to be very well kept in mind, as Dr. Keerthi has already discussed. The arthritis, history of fever, rashes, abortion histories, and all these have to be kept in perspective of different autoimmune diseases. And as per the treatment, it is just not our take on that. We have to see what, as per the sepsis vis-a-vis the autoimmune disease, the flare-up. So whether to treat sepsis first or to treat the autoimmune disease first, the complications of either which is more predominating, or the manifestation of the either two which is more predominating, treating that entity first.
Okay.
Yeah.
Ma'am, what is your final take? See, we have been seeing autoimmune diseases in the intensive care unit, but what will be the percentage somewhere, even though the detection rate, or probably there is a lot of ignorance related to the diagnosis of autoimmune diseases. So what will be the percentage of these cases being overlapped? Somewhere between 10-20% or so?
You're asking me, like, in patients who present to the ICU with multi-organ dysfunction,
Yes,
how likely it is that there would be an autoimmune disease? So frankly, I cannot give a percentage here. But yeah, maybe at least 5 to 10% of them could actually be having autoimmune diseases. And as rightly pointed, history taking is the most important thing. Having a clinical suspicion, because if you do not have in your mind, you will never catch it. So having an autoimmune, having a suspicion in the mind is the second thing. And ultimately, evaluating on those lines is the third most important thing.
So on the occasion of Women's Day today, International Women's Day, we have a fortunate to have both the women leaders here who have been a part of their clinical areas and leading the clinical areas. Happy Women's Day to both of you, Dr.
Thank you.
Keerthi
Thank you so
ma'am
much,
and
sir.
Dr.
Thank you so much.
Monica Soni. Both of you actually spread your knowledge or wisdom on the platform today. This must have been help to all our participants across
I'm
the
sure.
India who have joined from different parts of the critical care departments of India. And probably, as you rightly pointed out, a patient who is young and maybe a female, I'm not sure whether that also still continues to be an important component in lupus.
That's definitely there, sir. But there
Male
could be
lupus,
males
we
also
do
who
get male
present.
lupus also.
Yeah.
So being on Women's Day, this may not be a right way of, but a female, young, and probably having a constitutional symptoms for longer than expected in an infective etiology, and probably the clues with, as Madam pointed out, any typical rash, any lesions of significance should give you a clue, and keeping the suspicion on evaluating and a teamwork. Whenever you in doubt, probably a teamwork involving a rheumatology, involving the primary clinicians in that discussion, and going back and taking history and getting further evaluation may be the way forward. With this, I thank both of you, all the participants who joined us. And
Welcome,
I think
sir.
Dr. Keerthi has another program to line up on a Women's Day. So I conclude the session. Thank you, both of you, ma'am.
You're
Thank you
welcome,
so
sir.
much.
Thank you so much.
We
Thank you.
enjoyed the
Thank you.
session.
Yeah.
There was a lot of learning exercise for all of us.
I'm sure.
Me too. Okay, sir. Bye.
Thanks, Keerthi.
Bye, ma'am.